obesity-related disease. And so since obesity is pretty common, no matter what other syndromes you might have, this is definitely a potential for a common problem. So basically what's happening in sleep apnea, again, is your tongue and your soft palate are collapsing back upon themselves. They do this recurrently during the nighttime. And every time it collapses, your brain wakes up for about 5 seconds. Okay? You go back to sleep, eventually you collapse, you wake up again. So your sleep is actually quite disrupted during the night. So the main common symptom, one of the major symptoms of sleep apnea is being sleepy during the daytime. In general, sleep apnea is more common in men. It's more common in the middle-aged and elderly. It's more, very common in obesity, and we're seeing, there's no end to us seeing it in Detroit, quite frankly, because Detroit's a very obese city. So that's a common problem. And just in case, I always have this on here, enlarged tonsils. This is more true for younger people than older people. But if you have a younger relative who snores real bad and they're thin, they should have their tonsils checked out. So symptoms while you're asleep. So the most common symptom of sleep is the snoring, okay? And the snoring is bothersome to the bed partner, not to the patient generally. It's usually loud. It's habitual, meaning that it's there most nights of the week. It's irregular, because when the airway does collapse, the snoring stops, okay? So the snoring is from your uvula and your palate fluttering, okay? So if it collapses and shuts down, it stops, so the snoring goes away. Usually bothersome to others. If it can be heard in another bedroom, bad, okay? And that's often something to ask about. If there's someone here who is single, that would be something to ask other people. They ever come visit you, whatever, can they hear you snore in another room? Or if you go trips, which I see a decent number of people who live alone, but they go on trips with friends. And the friends are the ones that tell them, we ain't going on another trip with you unless you fix this. So witness apneas, meaning that the patient is seen stopped breathing. And then they have restless sleep. Again, sleep symptoms while awake, the most common is the excessive daytime sleepiness. But often people with sleep apnea do not wake up feeling refreshed. Okay, they might have been in bed 7 or 8 hours, thought they were asleep, and they wake up just not feeling good. Often will have a morning headache or a dry or sore throat. Again, the fatigue and tiredness. So sometimes people with this don't present with so much sleepiness, but again with fatigue. And so if you have, and since fatigue though is a common syndrome of Parkinson's, you know, is it sleep apnea or not? But if you're really snoring and that fatigue, it might be worth having it checked out because we might be able to fix some of that fatigue by treating the sleep apnea. So sleep apnea is one of the 2 diagnoses I talked about that we need to have you come to a sleep center, okay? The sleep studies, depending upon where you live though, are either done in the center. We're slowly moving to having them done at home as well. And I'm not sure what quite the most common thing here is in Ontario at the moment. But we are slowly moving to trying to do more of this at home. Usually, if you have sleep apnea, usually what you end up doing is being on something called nasal CPAP. And CPAP stands for continuous positive airway pressure. And it's a mask that you can see this gentleman wearing. It's connected to a box that these days are the size of a decent Kleenex size box, a box of tissues, usually rarely bigger than that. And basically, it's delivering a positive pressure to your airway. So if your airway, you can think of it as your airway's collapsing, and we're basically splinting it open, okay? It's pretty, at some level, barbaric, but that's the way it is. This was actually a major improvement in treatment for sleep apnea because we used to do tracheostomies on everybody. Didn't mean to go forward yet. Nasal CPAP, in general for sleep apnea, is a very effective treatment. People who do wear their CPAP usually feel much better night's sleep, better improvement in their sleepiness during the daytime. We can really make people feel a lot better. There are other modalities of treatment for sleep apnea. But in general, we would not generally do those for anybody unless they really can't wear their CPAP. So I'm not going to discuss them today. So restless leg syndrome is a common problem in Parkinson's as well. This is a common sleep disorder in general. It's now estimated about maybe upwards of 10% of people have this. This is a disorder characterized by unpleasant sensations in the legs when sitting or lying still, especially at bedtime. It often presents as insomnia, but can present as excessive daytime sleepiness as well. So multiple studies show that in Parkinson's there's about a 50% prevalence of RLS, which is way higher than the general population of 10%. Generally, people with Parkinson's develop restless legs at a much older age of onset, and they are less likely to have a family history. This is, in people without Parkinson's, this is a very highly familial disease. If your mother had it, you're going to have it, and your children are going to have it. But in people with Parkinson's, that's not true. Generally, people with restless legs and Parkinson's have greater symptoms and disability, greater cognitive dysfunction, and they've been on dopaminergic therapy longer than others, although the main treatment for this is also dopaminergic therapy. These are the 4 symptoms of restless legs. This does not require a sleep study or anything like that for diagnosis. Basically, it's an urge to move, usually characterized as a creepy, crawly, ants running up my leg type feeling, primarily in the legs. That movement is that urge is relieved by movement. Okay, so they get relief by moving their legs. Okay, worsening of symptoms by relaxation. So in the position you are all sitting in right now, you should not develop restless legs. It's when you get into your recliner at night and lift up your legs, or when you get into bed at night and lift up your legs, that you're going to have this problem. There's day-to-day variability, but generally worse in the evening and early at night. So some people have very sporadic symptoms. Some people, this can bother them every night. Again, this is often there's often a family history in this disorder. The other thing that happens is people move their legs at nighttime. So once they are asleep, they kick. And so often, again, that's reported by the bed partner. If you don't have a bed partner, one clue to that might be how messy your sheets are in the morning. If your sheets are really messy, meaning you just can't throw them back up and over the bed, there's a chance that you're kicking your legs at night. The link with Parkinson's disease is that RLS is also a dopamine deficiency disease. Okay, and so that's why we treat it with dopaminergic therapy. There are 3 drugs that are now, I don't know, I'm assuming they're all approved here in Canada. There's 3 drugs approved by the FDA in the United States for restless legs: Ropinirole, Requip, Pramipexole, Mirapex, and Rotigidine, which I don't know the brand name because it just got approved in the last few weeks for restless legs. Since many people are already on this, though, in Parkinson's disease, we would likely move on to doing opioids. So narcotics are a fantastic way of treating a restless leg syndrome. A little like hydromorphone or sometimes even a little bit of codeine at nighttime is a very effective way of treating restless legs. And the other thing you can do is use anticonvulsants, particularly gabapentin, can be helpful for this disorder as well. And the last one I'm going to talk about is REM behavior disorder. So this is the other diagnosis that does require an overnight visit in the sleep lab. So REM behavior disorder is characterized by a sleep-related injury, usually to self, but not uncommon to bed partner. And actually, some people would say it's more common to the bed partner than it is to self. And the reason for that is that there's dream enactment, but the problem is that there's altered content of the dream process. Okay, so people with RBD do not dream happy. They dream unhappy, scared, frightening. Okay, so they're vivid, intense, described as nightmares. There's fear and anger. They feel like they're being chased by people, by animals, and so what they do is they fight back. Okay, however, the normal inhibition of your motor function is gone. So therefore, you actually act out your dream, okay? And so that's where the bed partner gets hurt because the you're doing this, and so the person next to you is going to get hurt. Up to 50% may not recall the unpleasant dreams, but the bed partner usually confirms the thing. Again, you can injure yourself. My most classic, I shouldn't say classic, my most interesting case of this is actually the former juvenile officer who woke up, who had this happen one night, thought he was being chased by kids, got up and shot his hand. Okay, he took the gun out of his bedside and shot himself. So this actually can be a quite, disabling process, disease. So clinical RBD can occur in up to 45% of patients with Parkinson's. Or PSG documented RBD. So you may not have the symptoms, but if we were to do a sleep study of you, we would see it during the night. It can be up in 60%. Most are men, usually associated with longer Parkinson's duration, orthostatic hypertension, meaning that your blood pressure goes down when you stand up, and a higher dose of your dopaminergic agents. And it's more common with the rigid akinetic subtype of Parkinson's disease. The other interesting thing about RBD is it's actually now considered a prodrome to Parkinson's disease. So there's now evidence that if you have RBD isolated from anything else, that anywhere from 7 to 10 years, you are either going to develop Parkinson's disease or Lewy body dementia. Okay, and so this is now considered a prodrome to something else going on later in life. It's uncommon in the general population. It is a male-predominant disease, generally only seen in people over the age of 50. And is generally treated with clonazepam. So clonazepam is one of the older benzodiazepines we have. And we usually use a dose anywhere from 0.5 to 2 milligrams. Clonazepam is a very sedative drug, though, very sedating drug. So we usually try to use the lowest dose possible because the problem is if you wake up too early, it could have residual effects in the morning hours. And it's also a drug that you got to be careful with because if you were to get up at night, say, to go to the bathroom or something, it would be very easy to fall because you're not waking up enough to really do those actions that you need to do. So it is a drug that we use cautiously, but it's a fantastic drug for RBD. And it's also important to maintain a sleep environment. Every once in a while, these people actually get up and also walk, okay? And so you got to make sure that they aren't going to go downstairs. Edges should be protected, stuff like that, just to make sure that there's no problems that way. And I believe that is the end of my lecture. So again, I'd like to thank you for having me. And I think there's going to be time for questions, Tracy?
Yeah,
yes.
I think we've got a few minutes. Does anybody have any questions for Dr. Rowley? Do we need spritzer bottles, putting everyone to sleep, the daytime sleepiness? Yeah, right here.
Good lecture, Doctor. Appreciate it.
No
one question. You didn't mention night sweats anytime. Is that a sleep disorder or is that something else completely different?
That's probably something completely different. There's a lot of different things that can cause night sweats at night, but sleep doctors generally don't deal with that type of stuff. It's usually general medicine doctors or some other group like that. So we wouldn't consider it a sleep disorder.